Welcome to Derm Drop, your TLDR in dermatology. This is episode 3, and I'm David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community that are interesting and impactful. Our first quick pick poses the question, are prurigo nodules actually mini skin migraines? Well, not exactly, but when a patient with prurigo nodularis was treated with the migraine biologic erenumab, her prurigo nodularis got better too. That's because both conditions are driven by overexpression of calcitonin gene-related peptide, or CGRP. And erenumab, sold under the brand name Aimovig, blocks the CGRP receptor. In migraines, CGRP regulates cerebral vascular tone, and in prurigo nodularis, it is active in the crosstalk between sensory nerves, mast cells, keratinocytes, etc., that results in neural sensitization and neurogenic inflammation in lesional skin. Galderma has centered its marketing of nemolizumab around IL-31's role in the neuroinflammatory pathology of prurigo nodularis, and this case report in the February 25, 2025 issue of JAMA Dermatology supports this positioning, as IL-31 can directly trigger the release of CGRP from sensory neurons. That's one of the reasons why Nemluvio is also effective in atopic dermatitis, as CGRP is thought to mediate a shift towards Th2 inflammation, and higher levels of CGRP correlate with increased severity of itch. Thanks to the authors for sharing this fascinating case and elucidating the shared pathophysiology between such seemingly unrelated diseases as migraines and prurigo nodularis. Hashtag neurodermatology. Our second quick pick asks, is it topical steroid withdrawal or just an eczema flare? And this is an important question because those who question the existence of topical steroid withdrawal and its validity point out that those who claim to have it and experience it often have underlying atopic dermatitis, and discontinuing their medication would naturally result in a flare of their disease. Well, according to the diagnostic criteria derived from a multimodal pilot study conducted by researchers at the National Institutes of Health, or NIH, and published March 13th, 2025 in the Journal of Investigative Dermatology, if it's eczematous and includes burning, flushing, or thermal dysregulation, and 3 of the following: bone deep itch, profuse peeling, red sleeves, loose skin, hair loss, neuralgia or quote-unquote zingers, lymphadenopathy, swelling/edema, or dry eyes, it is in fact topical steroid withdrawal. Interestingly, symptoms of TSW may appear in areas not exposed to topical steroids. Why is that? Well, maybe it's because people with TSW have higher circulating levels of nicotinamide. So you know you have topical steroid withdrawal in the room with you. How do you treat it? Well, believe it or not, you treat it with metformin. Metformin and the metformin-like supplement berberine are mitochondrial complex 1 blockers that prevent the formation of nicotinamide. But I'll warn you, it's not a quick fix, as participants reported improvement in 3 to 5 months. Thank you to the many authors on this publication for providing much needed guidance on how to identify this under-recognized entity. Hopefully, this helps the deniers realize that there is, in fact, a distinct pathophysiology behind TSW, or topical steroid withdrawal, and that these patients should be taken seriously. Hashtag controversies in dermatology. Our next quick pick is for those of you who are wondering where icotrokinra, Johnson & Johnson's oral, yes, you heard me right, IL-23 receptor blocker, expected to get FDA approval this year, is going to slide into your psoriasis treatment algorithm. It has already shown superiority over deucravacitinib in the phase 3 Iconic Advance 1 and 2 studies. But don't worry, Sotyktu, We're just as excited to see what you're going to do for our lupus patients. And Johnson & Johnson is so confident about its performance that it's moving forward with a head-to-head against its own biologic, ustekinumab, in the phase 3 Iconic Ascend study. So long, Stelara. According to the Derms on Drugs podcast hosts, Dr. Laura Korb-Ferris, Dr. Tim Patton, and Dr. Matthew Zyrus, icotrokinra will compete in the Cosentyx/Ilumya ballpark. Want the numbers? Well, at week 24, 65% of icotrokinra patients are hitting PASI 90 and 40% are reaching PASI 100. Those are impressive numbers for an oral in this space. So what about safety and side effects? They're same as placebo and consistent with what we are already used to with other IL-23 inhibitors. So how'd they get an IL-23 into a pill? That was my question. They did it by formulating a peptide with bioavailability properties that limit digestion prior to absorption into the bloodstream. Yay, chemistry. And fun fact, as groundbreaking as icotrokinra is in dermatology, semaglutide has an oral peptide formulation for diabetes marketed under the brand name Rybelsus. So you beat us, diabetes. But the real game changer is finally having a highly effective pill option for adolescents with psoriasis, as patients down to 12 years old were included in the studies and expected to be included in the pending approval. Hashtag biologics gone oral. And finally, if you need a systemic to stabilize vitiligo before the oral JAKs storm the stage in 2026, hit them with dexamethasone, 1 milligram per 50 pounds, that's 23 kilograms, every Saturday and Sunday for 3 months. Then transition to maintenance therapy with topical ruxolitinib, corticosteroids, or calcineurin inhibitors. And don't forget the phototherapy to stimulate repigmentation, as that's an important piece of comprehensive vitiligo care. If you don't have a light box in your clinic and your letter of medical necessity for a home unit fell on deaf ears, have your patient start with 5 minutes of sunlight. Yes, sunlight. A dermatology provider is actually going to recommend sunlight in these cases because, again, light is an important component in vitiligo treatment to stimulate repigmentation, as medications just stop the inflammatory process. So if you're going to do sunlight phototherapy, have your patient on a similar schedule and titration criteria as an in-office narrowband UVB protocol. For example, 3 days a week beats 2, and surprisingly, whole body is better than spot treating with an eczema laser such as extract in order to prevent next month's lesions. So it's just like you tell your pimple patch adorned acne patients. You don't want to spot treat because you're just chasing after existing lesions. You're not preventing new lesions. Same holds true in vitiligo. Shout out to pigmentary disorder expert and immediate past president of the Global Vitiligo Foundation, Dr. Amit Pandya, MD, FAAD, with the Palo Alto Foundation Medical Group, who shared these pearls on episode 72 of the Future of Dermatology podcast. 3 JAK inhibitors are in phase 3 trials now, but even when they are approved, they will not work as fast as Dex. So keep it in the toolbox for rapid stabilization while you're appealing povorcitinib from Incyte, ritlecitinib from Pfizer, or upadacitinib from AbbVie for long-term use, as Opzelura is limited to 10% body surface area, tacrolimus doesn't work as well below the neck, and triamcinolone is tricky on as yet unaffected or subclinical skin. Other key takeaways from the podcast include recognizing trichome, confetti, and Kebnerized lesions as signs of actively progressing disease, and that the bony prominences, including hands and wrists, feet and ankles, elbows and knees, and other areas without hair, or greater than 50% leukotrichia, and depigmentation greater than 2 centimeters have poor prognoses as melanocytes can only migrate about a centimeter before getting stuck. But with a nearby follicular reservoir, even long standing lesions may respond, so there is hope. Get in there and dex it, then exit. Hashtag dermatology hacks. And that's it for episode 3 of Derm Drop. Thanks for tuning in and stay tuned for more.